Hello, hello everyone. Welcome to Medicoz Community. So today was your NEET PG 2023 exam. How was it? Yes, I've heard that it is a lengthy paper and the time was difficult to manage and so and so. But whatsoever, it is all over. Now it is time for you to relax and but it is also important to learn from your mistakes and go forward. It's okay if you have done good, that is well and good, and it's okay if you haven't. There is always a next time and you can always improve. So today we'll be discussing from the recall questions in a very brief manner. We have already discussed luckily almost 5 to 6 topics that have been discussed in the high-yield MCQs by Medicoz Community Live in Radiology session have been asked today in the exam. So we'll go through them again so that your concepts will stay strong, and also we'll have at the look at the questions in a very brief manner. So let me start the session. So the first question, and most of you have confused it with some other things also. This might not be the exact question, but we are only discussing the topics. So, what is the most likely diagnosis? Here, this is this is a hyperdense area in the brain, which is banana shaped, as we have already discussed, and here we are not able to see if it is crossing the suture line or not, just like in your exam. So the most differentiating point is this is this is more biconvex shape and this is banana shape. That means concavo-convex shape. Yes, it was a lengthy paper, that's what I have heard, and it is moderately difficult. I can see from the comments. Yes. So let us go in detail about this. So differentiation between epidural hematoma and subdural hematoma is very important. First, we'll see about the etiology. Why does an EDH occur? It is due to a injury to the arterial blood, mostly middle meningeal artery in the temporal region and parietal region, and it is rapidly expanding, giving a biconvex shape. So this is the torn middle meningeal artery bleeding into this and giving a biconvex or lentiform shape. The dura is pushed away from the hematoma, and this is the skull fracture. And it can cross the midline. This is subdural hematoma. It is slowly expanding. This is because of the venous blood and it is banana shaped. Okay. The dura is attached to the skull, so it cannot cross the falx or the tentorium. It can cross it. This cannot cross the midline, but can cross the suture. This cannot cross the suture and can cross the midline. So this is the important points you have to keep in mind. And regarding the subarachnoid hemorrhage, it generally is in the sylvian fissure. Let's have a look at the CT axial sections. This is the normal healthy brain, and this is the subtle little amount of hyperdensities which you are able to see here in the banana shape, and this is an SDH. And this is the biconvex lentiform shape, IDH. This is the intraparenchymal hemorrhage within the ventricles, and this is the also there is hemorrhage in the ventricles as well as in the parenchyma here, and this is only the hemorrhage inside the ventricles. Subarachnoid space we are able to see subarachnoid hemorrhage we are able to see the hyperdense regions in the sylvian fissure and the basal cisterns, which is filled with blood, which is having a blood attenuation. So this is SDH. SDH causes are also important. It can be mostly it is because of non-traumatic and non-traumatic uh, idiop idiopathic can also be there. That comes under non-traumatic, and aneurysms generally rupture and cause subarachnoid hemorrhage. Traumatic subarachnoid hemorrhages are also common. So the first investigation to do is a CT angiogram to rule out any aneurysms. Yes, the other subjects will be discussed briefly. We just got done today, so it will be done within the next coming few days. You don't have to worry about it. It's coming to the second question. A young man with pain and stiffness with image similar to bamboo or dagger spine. That was what was described by the students today for us. So this is the image for dagger spine. This is and mostly in the clinical setting also they will have pain while bending over. That is also an important clinical feature for us. So this is the bamboo spine because of the extensive syndesmotic ankylosis, and this is the dagger spine. This is due to the ossification of posterior longitudinal ligament. There is also fusion of the sacroiliac joints, which is also seen in this case. The most important differentials for sacroiliac joint involvements will be psoriatic arthritis, in which it will be asymmetrical. In ankylosing spondylitis, it will be symmetrical. In enteric arthritis, reactor, writer's arthritis, and all, there will be uh, bowel involvement as well as sacroiliitis. So that is how you differentiate it. So next, a 22-year-old man, a radiograph of left lower limb, which shows a lucent eccentric epiphyseal subarticular lesion arising from the metaphysis, and it crosses the closed epiphysis. Some of the students have told it is a mature skeleton, but most of them are. I have put the question like that, but recently, just now, I have received another information that the answer which was the question which was asked for, the answer is an aneurysmal bone cyst with a classical soap bubble appearance in an immature skeleton. So this is an aneurysmal bone cyst, and the classical description which I have given is from arising from the epiphysis in a mature skeleton going into the metaphysis. This is a GCT, giant cell tumor. Okay. Next, 44-year-old woman with pain abdomen. What is the sign and diagnosis? In the liver, we are able to see a hypodense area, and this is the sign inside it. So, what is this? This is definitely a cyst with a membrane inside. So, it is a hydatid cyst. The layers of the hydatid cyst are important, which is formed by what? The pericyst is formed by the host itself, that is the human body, ectocyst, endocyst, and the daughter cells, and all of that. Okay. So, there are signs for hydatid cyst. There is water lily sign. Probably what they have asked today is serpent sign. That is the crumbled membrane appearance inside the uh, cyst. Okay, there is air crescent sign and reverse air crescent sign depending upon the cyst if it is ruptured or not. So yeah, let me go to the next question and the most important high topic. Lobar collapse and associated silhouette sign has been asked. So first, it is important to know about the anatomy. This is the right lung, this is the major fissure and the minor fissure. So this is how the common CT appearance looks. So let me go into the pathologies. So this is the right upper lobe dividing the minor fissure is the minor fissure, and this is how it looks on the lateral x-ray. So when it comes to yes, when it comes to the right upper lobe, there is a silhouetting of the right paratracheal stripe. So this is the silhouette sign. That is, if there are two structures in the same plane, there will always be obscuration between them. That means we will not be able to see proper delineation between those two structures. If you are not able to see the proper delineation between these two structures, that means it is silhouetting. That means it is obscuring. That means they are in the same plane. That means there is some problem in the same plane. So always remember this. For the right upper lobe, the silhouette sign will be seen in the right paratracheal stripe, as we are able to see in this image. However, the question that was asked was about the right middle lobe, where the right heart border will be silhouetted. Classically, on the lateral X-ray, we'll be able to see this sign as a lentiform area in the middle area. So here the right heart border is obscured, and this is the minor fissure. That is why some of you might have confused it with the pleural effusion. So uh, pay attention here. So, and then let us also see about the other one. Right lower lobe, there is silhouetting of the right heart border and the right hemidiaphragm. And for the left upper lobe, there is silhouetting of the aortic knuckle. And for the left lower lobe, there is silhouetting of the descending thoracic aorta and the left facial sign, because the norm, this is the V-like opacity in the upper zones. And the, okay, some of you think that it is not silhouette sign which is asked in the paper, but this is the information what we have got. let's uh, let's have more opinions. This is only a brief discussion, we'll see about it later. So next question, steeple sign was asked. Where is steeple sign seen? This is the, okay, this is the trachea which is narrowed in the upper part because of croup laryngotracheobronchitis, seen in children with moderate amount of fever and other clinical features. Okay, the thing which you have to differentiate is it with the acute epiglottitis. Generally, you will be given a lateral X-ray, and there, this is the classical thumb sign seen in the acute epiglottitis. Next, ground shepherd crook's deformity is given. This is the shepherd crook. I have shepherd's hook. I have given a image here. This is a actual shepherd's hook, and this fibrous dysplasia. There is deformity in the upper in the femur, and this is the ground glass matrix, which where it is completely involved. It can be monostotic or polyostotic. Fibrous dysplasia is a must know spotter. Okay, most of you think it was pleural effusion only. Okay. Next, I haven't received a proper thing how Pancoast tumor was asked. So basically, Pancoast tumor is superior sulcus bronchus is involved, and there is a upper zone opacity, most commonly on the right side. So this is how a Pancoast tumor appears. And then there was a question about midline shift of the mediastinum. So midline shift of the mediastinum, we have to see where the tumor is. If there is ipsilateral shift or contralateral shift, that is important to know. If there is ipsilateral shift, then there is something which is pulling towards it. That means if there is fibrosis, or if there is a mass which is causing bronchiectasis changes or traction bronchiectasis, or anything which is pulling towards us, then there is a ipsilateral mediastinal shift. That is, the trachea is deviated towards the side of the lesion. If there is a contralateral shift of the mediastinum, that is, it is pulled away from the lesion. So if there is a massive pleural effusion, it will pull it away from it. So the most important thing you have to remember at this level is, if there is ipsilateral shift, it is because of fibrosis, and if it is contralateral shift, it is because of the pleural effusion. Okay. Next, midline neck swelling, which is moving on protrusion of the tongue. So the only important differential here is a thyroglossal cyst. So here we, in the image, we are able to see there is a cyst in the midline, and this will generally move with protrusion of the tongue, because it lies along the line of from the foramen cecum to the hyoid. There is a part of the remnant thyroglossal duct that is where there is secretions in it, and it is forming a cyst. So Sistrunx operation is done, and it is removed. So this is the foramen cecum, this is the lingual tonsil, and this is the hyoid and the thyroid gland. So along the line, there is some remnants within, and there is some cyst forming. There is some fluid secretion. So that is how the thyroglossal duct cyst occurs. And an important another differential is, if there is a hyperdense area around the foramen cecum, and then we have to think about the lingual thyroid instead of a cyst. Other midline cysts can also be there. Cystic hygroma sometimes occurs in the midline also, but it is mostly a lateral mass. Okay. Yeah, so these are the 10 questions, and we have covered the related topics regarding it. And there are a few questions. Okay, ground glass appearance with which bone? Uh, I I don't know. They have just told about fibrous dysplasia. Fibrous dysplasia's characteristic feature is having a ground glass appearance. Okay, so this is the session. We have come to an end to it. Do not get disheartened if some of them are wrong. We never know until we get the results. So this is the time for you to uh, not take tension, chill for some time, and but still keep studying. It's always a learning process is always there.